Yay. Yep. All right. So as you already knew, we're talking about pediatric fractures today. No disclosures. We're going to go through the diagnosis, how to describe it, especially if you're trying to describe it to someone else on the phone.
Can
And
you
then
throw up, Mandy, can you throw up your slide view? You're just on like your edit
I
mode.
know
There you
I
go.
put it up. Stop. Um, so when you're talking to people, like if you're trying to describe it on the phone, like if you need to talk to someone about it and they can't pull up the picture, obviously you want to start with the bone name, where it is in the bone, whether it's comminuted or not, what the fracture line looks like, how displaced it is, whether there's articular involvement or not, and whether it's open or closed. So if you're like, on the field or something. So for all of you people who don't do pediatrics, the epiphysis is the portion of the bone that is, in the joint. Then the physis, metaphysis is next to the physis. The diaphysis is the long part. And then the articular surface is attached to the epiphysis. So that applies to all of the long bones, obviously not to like the bones of the midfoot or hand, but all of the long bones. So the fracture patterns, comminuted, they're in several pieces. Green stick, only one side of the bone is fractured, which can, particularly in the radius and ulna shaft fractures, that can actually cause problems. If you have a complete fracture through the radius, but a green stick through the ulna, the green stick fracture can sometimes make it more difficult to reduce the radial fracture, if that makes sense. Transverse fractures go all the way through. Open fractures, obviously the fracture fragment is sticking through the skin. And then closed or simple fractures kind of go all the way through. And then buccal fractures, you guys should see hopefully 1 million of those this year and should be able to manage those pretty easily. So on the left, you can see non-comminuted fracture. This is still a complicated fracture here. Just because it's not comminuted doesn't mean that it's not complicated. And this one is actually likely going to cause instability in the ankle joint and need surgery anyway, but it is not in several pieces compared to this ankle fracture over here that is obviously, in several pieces, both the tibia and the fibula. And then the direction of the fracture line, this is a transverse fracture because it goes straight through the bone. This is an oblique fracture because it goes more diagonally in orientation, and then spiral fractures. And you can have spiral fractures in older kids, but when you see them in younger kids who are not participating in sport, you need to be worried about abuse. And so we do have child abuse specialists at our hospital that we can call that will tell us what else we need to be doing. If we see a spiral fracture in like a 9-month-old, for instance, is pretty suspicious because they shouldn't be walking and causing their own spiral fracture. Sometimes we will see them like older siblings trying to get them out of a bed or something can sometimes cause these. So it's not always nefarious, but it is definitely something that you take into consideration when you're looking at it. Oftentimes this is a frustrated, tired parent when, grabbing both ends of the bone and twisting. Again, this is a green stick fracture. You can see here, there's a little, fracture on this side of the bone, whereas over here, we're still intact. Because this is a pretty young person, if you look at how and we'll go over this later, the growth plates in the elbow, this is a young person who may remodel just fine, even though there's another fracture further down the bone, but you just will sort of have to. This one, obviously, you would be getting pictures of the elbow and the wrist as well to figure out exactly what's going on. So they may or may not have difficulty in reduction, depending on what the wrist looks like. This is your standard torus fracture. These always do really well, and you'll see a bunch of these. So describing the angulation can sometimes be confusing to people. So if you're describing angulation, you want to describe either which direction the distal fragment, so the distal radius here is displaced volarly, but the apex of angulation is dorsal. So you can describe both, you can describe one or the other. But if you're going to say that this is dorsally angulated, you need to say that the apex is dorsal because the distal radius is volarly displaced. So that is sometimes confusing to people that you're describing the distal fragment as opposed to the proximal fragment, but that is just the convention. So just make sure that you are not confused. And then this angle, you're just measuring the angle here, which is about 40 degrees. This would be described as radial displacement of both of these fracture fragments, and obviously both of these fractures are going to require reduction. So again, this is a tibial shaft fracture. The distal fragment is displaced laterally. And again, this is just more examples because again, it can feel counterintuitive when you're looking at the picture about how to describe it. And then you want to describe, particularly in the radius ulna and tibia fibula, is it at the junction of this one is the junction of the middle and distal 1/3, or is it more proximal? Because all of those matter with how we're going to immobilize. So sometimes in fractures that are lower down in the distal tibia and fibula, you can get away with a short leg cast. Whereas this one is high enough up that likely this is, at least for a short period of time, going to require a long leg cast. So knowing where the fracture fragment is pretty important for deciding what your treatment is. And then articular involvement, typically we will at least run by the surgeons. Any fracture that involves more than 25% of the articular surface. So this is right here is about 30% of the articular surface. And then we may get a CT scan to determine whether or not the articular surface is congruent. If not, oftentimes, particularly in the femur or in the distal tibia, they need to be completely congruent to decrease the risk for post-traumatic arthritis. So, if you're thinking about like a 15-year-old kid getting post-traumatic arthritis, which typically happens in about 10 years, that's a 25-year-old kid with bad knee or ankle arthritis, and that's obviously not ideal. The Salter-Harris fractures, these you need to memorize whether you are adult or not, at least for when you take your test, because this does always come up on the CAQ. There will be a question about a Salter-Harris fracture because it's one of the few that doesn't tend to change. So this is a typical bone. The type 1s go directly through the physis. Type 2s go through the physis and out the metaphysis, or, if you want to use this mnemonic, above. Type 3s go through the epiphysis and the physis, sorry, and then type 4s go through the epiphysis, physis, and metaphysis, and type 5s are a crush injury. The crutch injuries, oftentimes you don't see initially and oftentimes don't get diagnosed until years later when there's impairment in growth. And then technically there is also a type 6, which is not going to come up on the test, where there's periosteal injury, which causes scarring and impaired growth on one side of the growth plate. So type 2s are the most common, which is probably not true. It's the most common that we see in clinic. I think a lot of the type 1s, because they, may have mild swelling and aren't as uncomfortable, oftentimes don't present to clinic. So I suspect there are actually more type 1s than type 2s in the world. We just don't see as many. So I don't think it would come up on the test which one is more common, but if it does, it's type 2. So forearm and wrist fractures. This kid is kind of a standard. You're going to see all fall. A 9-year-old soccer player who falls on an outstretched hand. Little bit of limited range of motion and strength. We always check the nerves, which I'm sure you guys have already seen me do, to make sure everything is intact. And this is just your standard buccal fracture with minimal angulation. The big question on these is then how are we going to manage this kid, right? So a lot of it depends on who you're treating. So if this was a kid who was playing soccer in the backyard with their cousins, but never does any contact sports and is, normally a chess player and involved in student government, we might actually you can put them in a Velcro splint like this. That is totally reasonable. These fractures aren't going anywhere. They're very stable. And if they're comfortable in a Velcro splint and they're not playing sports, that's fine. That's not often what we're seeing because we're mostly seeing athletes who are involved in contact sports. So I would usually not use this, but in some of the younger kids, it's perfectly fine to do a Velcro cast. I generally encourage the waterproof removable Exos cast. And there is some new brand out there that I missed the in service on, but there is another brand that exists so that you don't feel like there's any commercial bias. The Exos is up until the last year has been the only brand available for kids who are not going to be reliable and will refuse to wear the Exos when they're playing sports. Then they can get just a regular cast. For most buckles, you can, if you want to do a waterproof cast, if you're at one of our offices that actually has the waterproof casting material. I will tell you from experience at my own house that the waterproof cast material is way itchier than the regular cast material, and it's kind of annoying. So if it's not during the summertime, then oftentimes I will just do a regular cast, if we're not worried about them getting in the pool just because it's so annoying. And then these are just the many varieties of the Exos casts that are available in our clinics. So there are radial and ulnar gutter casts, just the standard forearm casts, ones that involve the thumb, which are short. So you have the distal, the interphalangeal joint of the thumb is available. In here, it is not available. So just depending on the fracture type, we have lots of different Exos available. So which ones actually require a cast and can't have an Exos? So complete transverse fractures like these could become unstable. So you're going to want to not just put these in a cast, but you have to do really good molding of this cast. So you're going to put your hands on either side of this cast, dorsal and volar, and you're going to hold it. And it takes a lot longer than you think. Like you're going to stand there for a good 3 or 4 minutes before that cast gets completely hard to make sure that this doesn't move. And this is one that we're generally going to look at again in a week to make sure it hasn't slipped off so that, they can go to surgery and get reduction plus or minus a plate if it depending on whether or not the surgeon thinks it's needed. But we would do that reduction that far out. Usually they use anesthesia. Sometimes in the ER, if you have a kid who's pretty cooperative, you don't have to do sedation. So forearm fractures are a huge portion of pediatric long bone fractures, about 40%. Distal radius is the most common that we've seen based on ER records. The closer the fracture is to the physis, the more likely it is to remodel. In the literature, this is the accepted angulation that typically we can treat without reducing. So if they're less than 10 years old, they can, as long as it's less than 25 degrees, you're good. If they're more than 10 years old, it's usually about 20 degrees. But I have seen the orthopedic surgeons accept more than that, closer to 30, 35 degrees. But I will generally check with the orthopedic surgeon if it's around the 20 to 25 degree mark. And sometimes if it's a pretty fresh fracture, you can actually get a little bit of reduction when you're applying the molding to the cast. The kid is not super comfortable while you're doing it, so it's nice to warn them ahead of time. And then when you are further away from the physis, so in the shaft, you can accept significantly less angulation. So if they're more than 10, only about 10 degrees. If they're less than 10, 15 to 20. And again, sometimes the orthopedic surgeons will feel you can accept a little bit more, but we'll generally call them and ask them to take a look to make sure that they don't need to see them and make sure that that works. So if you can get the reduction done in less than a week, it tends to be less complicated because kids heal a lot faster than adults, and it gets hard to move the fracture after a week or so. Sometimes they'll put in percutaneous pins if it's an unstable fracture pattern, or if they were in a cast and reduction was lost. Sometimes they'll have to do open reduction and internal fixation. And again, that is why we have you hang out with the pediatric orthopedic surgeons to kind of learn which cases require just a closed reduction with pinning, and open reduction and internal fixation. So that's why you hang out with them. So this was a kid who was successfully, this is a Salter 1 where the physis completely slipped off and was successfully reduced in the emergency department, and looked great post-reduction and had no growth arrest 5 months later. So this kid did great, but that is a significant fracture displacement that did really well with closed reduction and no fixation. When you are thinking about reducing, so if you're on the field and a kid is really miserable and you think that reducing them before you get them in the splint to send them down to the emergency department is going to work. So you're going to apply 3 points of pressure, and basically in the opposite direction of the angulation. So if they are angulated dorsally, you're going to put the wrist in a little flexion and push up, and exactly the opposite way around if they're angulated volarly. So you can see where you're going to apply your pressure. Again, I will do this with kids that have kind of borderline angulation when we're applying the cast to try to reduce it a bit. And Fred at the Mayfield Village office does this kind of stuff a lot. So it's nice when we have him around because he's pretty creative and does a great job with reducing people a little bit when we put the cast on. And in those people where we're definitely applying this kind of molding to reduce, I will usually get a picture after we put the cast on so we can see if it worked. So things to think about with distal radius and ulnar fractures. And both of these pictures were pictures of fractures where the original physician who saw them in the emergency room missed these dislocations. So the Galeazzi fracture comes with a radial ulnar dislocation. So you can see the radius and the ulnar are no longer aligned. This was mistaken for just kind of a buccal fracture with a little bit of angulation. And anytime a kid comes in with, especially with a ulnar radial shaft fracture or wrist, any injury, you have to make sure that their elbow is not painful. So you can see here that the radial head is dislocated. And this, and there is a green stick fracture here of the ulna that is allowing this radial head to stay dislocated. So this is going to require reduction here. And we've seen every now and then these will roll into clinic and we'll see them because it'll be a toddler and they're trying not to take them to the emergency department, which is totally fine. But, a lot of people who are not taking care of kids all the time will look at this and kind of not realize that this isn't normal looking. So just make sure you're always palpating the elbow and make sure you're looking for joint alignment because you can get dislocations with some of the fractures. Another common thing that we're going to see, 18-year-old right-hand dominant soccer player who fooshed on the left wrist about 12 days before they came into clinic. So this fracture that we're about to talk about is probably the most common, oh, by the way, fracture that I see other than sometimes the torus fractures. I think these are probably more common because teenagers will often ignore this because they don't always get super swollen. So this kid was seen in an urgent care and they got hand and wrist films that were read as normal. So this is why we always read our own films. They brought the kid back because he continued to have pain. He looked, minimally swollen. He was definitely tender in the snuff box. So if we had seen them originally and we hadn't seen the fracture on the first set of films, because they had tenderness in the snuff box, we would have casted this kid in the first place. But they did not get casted. They just got sent home. So we got radiographs with a scaphoid view. These are not this kid's radiographs, but for you fellows. So this is a scaphoid waist fracture. This is a distal pole fracture, and this is a proximal pole fracture. Which one of these three is most likely to have problems and need surgical management immediately, as opposed to waiting to see if they heal?
The first one.
It's actually the proximal pole. So because the blood flow comes for the scaphoid, it wraps around and comes from distal to proximal. The proximal pole fractures are more likely to go on and have AVN and non-union. So the proximal pole fractures almost always will get just a screw to start with. Then you're correct, the waist are the second one, followed by the distal poles, who almost always do fine. As an adult human being who doesn't have time to mess around with being in a cast for 4 months, if I had a waist or a proximal pole fracture, I would get one of my surgeons to just put a screw in the first place because it's a definable amount of time that you're going to be down, as opposed to potentially treating this for 12 to 16 weeks and having a non-union and then having surgery and then being out for another 6 to 8 weeks. And the same applies to like higher level athletes. So often your Division I or your national level athletes, even with a waist fracture that's non-displaced that could potentially do fine. Oftentimes they will get a screw to start with. But the waist fractures and the distal pole fractures, certainly we can try to manage without surgical intervention. So this kid happened to have a proximal pole scaphoid fracture, which you could see on the first set of x-rays. So they went on to get a little screw put in there, this little tiny screw. I think it was pretty easy to get him in within 2 days or so because the orthopedic surgeon took a look at it for us. This is a similar case, a 14-year-old swimmer who fell playing basketball, and his mom told him he was fine, he was fine, he was fine, and he continued to have pain and finally came in a month later. Had snuff box pain, pain with push-off, and pain with strength testing in the wrist. And he had this scaphoid waist fracture, which if you look at it, you know, it looks like there's a little resorption around the fracture site. So I did actually have the hand surgeon take a look at this one and make sure they thought it was okay, particularly because he was 4 weeks in, to go ahead and try to treat this conservatively. And they said to go ahead and try. He has, you can see he's got open growth plates, so his ability to, you know, heal potential is a little bit better. So we put him in a thumb spica cast for 6 weeks. And that was because he was 4 weeks out. So sometimes with the fresh scaphoid waist fractures, if they come in right away, sometimes we'll just do a cast to start with for a month and then switch them to the Exos. Which was interesting, the hand surgeon recommended that we make sure he was taking the Exos off for just some range of motion, no weight bearing on the wrist, but range of motion exercises daily. And I did let him compete swimming with the Exos on, which he liked. I mean, he wasn't getting his best times with the thumb spica Exos on, but he was happy because he was able to swim some, which seemed reasonable. And I was worried enough about him after we saw him at the 8-week mark when he wasn't completely healed that the surgeon said, go ahead and just get a CT and make sure there is some healing happening. And you can see on the CT scan that he did have some bridging bone there. And then by 17 weeks, his x-rays look completely normal. But that took a really long time for this kid to heal. And part of the reason why it took so long is because he hung out for 4 weeks before he came in. But that is actually fairly typical. I see, and Sue sees, Mary, like we all see a bunch of these who, because they don't get massively swollen all the time, they sit around and don't come in because they can tolerate the pain. So the proximal pole usually needs surgical management. Distal pole, they do really well and often only have to be immobilized for 4 to 6 weeks. The scaphoid waist, if they're minimally displaced, 90% of them will heal with 6 weeks of immobilization. Moderate displacement requires longer immobilization. And again, longer immobilization if they have a delayed presentation. And then if they're more than 1.5 millimeters displaced, we will generally, at the very least, have the surgeon take a look at them and decide whether or not they can be managed conservatively or not. So any questions about wrists before we move on to elbows and clavicles? We'll keep going. So this one is a kid that I saw a few years ago when we were still at the Green Road office. A football player, right-hand dominant, landed directly on his shoulder. He was unable to continue to play and had an obvious deformity of his mid-clavicle and pain there. So went originally to urgent care. I mean, this is obviously going to be a clavicle fracture. This slide you guys have to memorize, not just for clavicle fractures, but there will be questions on this particular slide on the CAQ of just, you know, what nerves supply what area of the arm and what reflex is associated with that nerve. So there's going to be at least one, maybe 2 questions that apply here. So I'm not going to go through all of these because you're not going to remember it just because I read this whole chart to you. But this chart should be something that you guys memorize. So that kid had a standard mid-shaft clavicle fracture, which 90% of the clavicle fractures we see are mid-shaft clavicle fractures. So, and they tend to do fine. We worry about them if there's, and I think I have pictures of this later, if there's significant tenting of the skin, if there's shortening of the fracture, then we worry about it. The distal clavicle fractures like this, actually, the radiograph got read as normal by radiology because they were calling this an open physis. But because he was painful and swollen and that's where he hurt, we decided that he really had a fracture. And you can see, like, when we repeated x-rays, he did totally fine. And he actually went back to play a lot faster than the standard mid-shaft clavicle fractures because it was so small and he healed so quickly. So if they're non-displaced with minimal angulation, sling for comfort. Occasionally, someone will be more comfortable in a figure of 8, but most of the time they're not, because the figure of 8 splints go right over top of where the fracture is and applies pressure on it, and people don't like it. I did have a kid show up recently from an emergency room where he got a figure of 8 and he loved it, and so we let him stay in it instead of using a sling. Depending on how much strength they lose and what sport they play, we'll sometimes need to do physical therapy for strength and range of motion. The younger kids need it less often than the older kids because they heal a lot faster. So, you know, the 8 to 10-year-olds can often get back to play in 4 weeks. The high school and college athletes who don't have open growth plates and don't heal as quickly can take 10 to 12 weeks to get back to play. So we want them to look good on x-ray and have no pain when we examine them to make sure that they're ready to go back to play, because these do have a high rate of refracture when we put them back into sports like football and hockey. So this was another one. This was a left-hand dominant kid who was tackled and fell onto the left shoulder and had immediate pain and swelling in the clavicle. Like them all, he had decreased range of motion because it hurts. He had a little more obvious deformity when you looked at him, but you can see this is about 2 centimeters shortened, and it's on his dominant side, and he's 16 years old. So he may get a little bit taller, but he does not have a ton of growth and remodeling potential left. So in an 8-year-old, we might be able to tolerate this kind of overlap. I would still show it to usually Wetzel in our case, just because he's the trauma guy who does the most of these to see what they think. But in this kid, a 16-year-old who is a quarterback and a pitcher and is hoping to play one or both sports after high school, this needs to be fixed or they're going to lose power because the clavicle acts as a strut for your scapula. And so you cannot generate as much power if the clavicle is short. And this has a high risk for non-union because it's so overlapped, and it's going to take forever if it does heal. So if this is a non-dominant side and a soccer player, maybe, oh no.
Did we lose her?
Yes.
I wonder if her computer died, maybe.
I'm guessing.
I'm
Yeah,
trying to interpret the oh no. I'm going to go with laptop died for 500.
Probably a solid choice.
As someone whose laptop dies so much, I brought my personal one today. I feel her pain.
We've all been there. I see you keep changing your background. What are you on now?
I'm with Ben today. So today
Oh.
I thought he'd appreciate the monsters, but I don't really know if he noticed it. He's like, is that a stadium? And I'm like, look at the flag.
But is he on the ice in the picture? That's really the question.
True. Well, I thought about just changing it to his face next. So we'll
Yeah,
see
Sorry,
if he
well,
notices that.
Am I
Yeah,
back
no
now,
worries.
Suze?
You're back.
Yeah.
Did your computer die? We're placing bets.
Yes, I swear. I looked at it at half time and it said it had 2 hours of power, and clearly that was a big lie.
Well, you're
So it
just
did not.
a power suck, apparently.
I know. So we will
Right.
always, and it's gotten, I will tell you, the surgeons are more aggressive now. So like when they first started fixing clavicle fractures, they were like, oh, 2.5 centimeters we fix. Now, like even the ones that are, you know, if it's a dominant side in an older kid, if it's a centimeter shortened, I'll at least have them take a look. The little kids, they, you know, Sue's had a 12-year-old, I think, who needed to be fixed recently.
Yeah, she was tenting and just unbearable pain. Can you share your slides again?
Sorry, I didn't realize it wasn't shared.
And my 12-year-old was a female who was pretty
Right, so
physically
she's a
mature
12-year-old
already,
girl might be close to,
and a dominant overhand athlete. So she was a right-sided softball thrower, but she literally was tenting.
yeah, so those are There are a lot of considerations that go into whether people get fixed or not. All right, can we all see it now?
Yep.
Yeah.
Good. Okay. So this was this kid's plate. They have lots of different shaped plates. They have plates for boys and plates for girls to make them work better. But the clavicle is kind of a funny shaped bone. So it's important to get the right size plate, which is, again, not our problem. We're supposed to figure out who needs the plate, but it's sort of interesting. So similarly, this is an 11-year-old with a similar type of fracture, and he actually did just fine, being managed conservatively. And I didn't bother because it's not right, but I didn't bother to repeat his x-rays 4 years later to show that his clavicle got back out to length and he did fine. But he had wide open growth plates, so everybody thought that he would do just fine. And he was able to go back to play at 5 weeks. He was pain-free and had enough callus at 5 weeks that he was able to go back. So again, age matters a whole lot. And whether it's dominant or non-dominant side matters a decent amount. So clavicle fractures are pretty common. On the PEDS boards, they'll say clavicle fractures are the most common fractures in kids. I suspect that is because they include the clavicle fractures that happen as a result of birth trauma, because it's not the most common fracture that we see in sports. It's definitely the distal radius, but it is pretty common. It's almost always the fall onto the shoulder, or sometimes like a helmet to the clavicle in either hockey or football. It can happen, with a direct blow, but usually they are falling onto a shoulder. You do not need to specify these radiographic series unless you're not in a regular normal hospital system. They will, if you just say clavicle series, you'll get AP and AP with a 20 to 60 degree tilt. But just so you know what a clavicle series is. But really important to remember that the SC joint can get injured with the same mechanism of falling onto the shoulder, and they're generally going to point to their clavicle as where they hurt. So it's really important. Every single shoulder exam, whether it is for chronic pain or an acute injury, just get into the habit of starting palpation at the SC joint for every shoulder exam you do, or you will miss it. Every SC joint injury that Dr. Briskin and I have seen in clinic was missed in the emergency room, everyone. And you can have very significant complications like airway compromise, pneumothorax, laceration of your great vessels, and brachial plexus injuries. So don't miss them. They're a big deal. You may see obvious swelling at the SC joint, especially if they are dislocated anteriorly, which, while this is super impressive looking because this athlete had an anterior dislocation, we don't worry about those quite as much. We worry about the swelling in the acute time period, obviously, but the posterior dislocations are obviously the ones that are more likely to cause laceration of vessels and other injuries. They will generally have pain at the SC joint with range of motion. And later on, years later, sometimes these anterior dislocations are still unstable at that joint. So when they abduct and forward flex, you can see it move. And generally, we just leave that. It's annoying to people. It's usually not painful. They're just like, look at this weird thing. And you're like, yeah, that is weird. But the surgeons don't generally tend to go after that because surgical fixation of the SC joint is kind of a nightmare. It's really important to ask them if they've had trouble swallowing, because again, you're worried about the loss of your airway and possible impingement of the swelling on the great vessels behind the SC joint. And I have had a kid who showed up having been sent home from the emergency department, who I said, well, did you have any swelling, trouble swallowing or breathing last night? He's like, yes, I'm definitely have a hard time swallowing. I was like, oh, dear God, so glad you're still here. So just, those are always questions to ask. So remember, you may be on the sideline with these people. So if you're going to send someone to the emergency department and you're worried about their SC joint, send them with a piece of paper saying that that's what you're worried about, because otherwise people may not think of it. And usually we have to get a CT scan to see it well. They will, a clavicle series can help some, I suppose. I don't think that we've ever been able to get away with just doing a clavicle series for these, but this was the CT scan on the one kid I had who'd had some trouble swallowing the night before. So you can see posterior dislocation of his clavicle there, but his airway and vessels were okay. So obviously, if they have airway compromise, that is going to get reduced. They generally have vascular stand in the room with them when they do it. And I have never seen a reduction, but apparently they just grab it with a towel clip and pull forward, which sounds terrible. If it's anterior mildly displaced, we can manage it conservatively, the same as you would a clavicle fracture. So whatever makes them the most comfortable. But it is a controversial area because it's tricky, you know, if they have posterior displacement and you reduce it, then what do you do? So sometimes they, you know, will put a screw or a pin in there, but they've had trouble with those sometimes migrating out of the bone and into other places. So that can be tricky. So it's nice that we're not responsible for that, but definitely the orthopedic surgeons will always have vascular on standby when they're doing these reductions if they're needed, which is pretty rare. We don't see it that often, but it happens occasionally. This next one, you'll see a lot of the fell off the couch injuries, jumping on the bed injuries. This one fell off the couch onto an outstretched right hand, had elbow pain and swelling. And, you know, because it was nighttime, they put the kid to bed, but in the morning when they were still refusing to use the arm, they came in. So this is, we will see a fair number of these. When you look at this kid, you can see there's this big fat pad anteriorly and posteriorly. So you should never see this posterior fat pad. Sometimes you will see an anterior fat pad, but it's not going to be this big where it's coming out like this. You generally, you know, it'll be 2 millimeters or so anteriorly. So this is, even if you can't find a fracture on x-ray in this kid, you presume it's a supracondylar fracture and you treat them as such. So in the very active kids, they will get a long arm cast for 2 to 3 weeks. 95% of the kids that I see will get the long arm cast because they got the fracture in the first place because they were jumping on the bed or the couch, and that's what they do all day long. I have had 2 or 3 families who are like, no, their sibling pushed them down, but they're really quiet and they just mostly hang out and color and play board games. Then they can go in a sling if they're comfortable enough. And then we will bring them back and recheck x-rays at 2 to 3 weeks to look for a periosteal new bone to confirm where the fracture was. So you're looking for, when you get x-rays, we usually will get AP lateral and obliques in our office, but AP and lateral from the emergency room is typically good enough. And then I'm going to just show you what we're looking for on the fractures. So this is the radiocapitellar line. In every single view, if you draw a line through the radial head and neck, it should intersect with the capitellum. So you can see here that the radius intersects with the capitellum. And then if you did the same thing on the lateral, the radius intersects with the capitellum. That's what's going to keep you from missing those radial head dislocations. And then the anterior humeral line, you draw a line through the anterior humerus, it should intersect the capitellum. So in extended supracondylar fractures, it will not do that, and those often need reduction. And then this is the radiocapitellar line on the fracture. So this is an example of the anterior humeral line not intersecting with the capitellum because this fracture is extended posteriorly. So this is going to need reduction and needs to go to the pediatric orthopedic surgeons. But you can see this is for someone who doesn't look at a lot of pediatric x-rays, you can see how these get missed in an emergency room. Like, I don't blame them for missing these, that they should have gone to the surgeon instead of us, because you know, elbows can be tricky to look at, but you guys will not make that mistake because you're getting trained with pediatricians also. And this is an example of a radial head dislocation. And again, when you look at this x-ray, again, this was missed in the emergency room. Like, this doesn't look so terrible looking, right? Like, if you are someone who doesn't look at pediatric elbows all the time, and a good cheat for people who end up in the world, if you're not sure if it's normal, get a picture of the other side. And you can tell what looks more abnormal when you compare it to the other side. But this required reduction surgically. So typically supracondylar fractures are Fuchs injuries. Those are most of the ones that we're going to see. It can be a direct blow to a flexed elbow, or a fall from a height, but mostly it's going to be a fall on an outstretched hand. Sometimes in the older kids who are playing contact sports, you'll see a blow to a flexed elbow. Swelling, tenderness to palpation, decreased range of motion. On the test, and this is another frequently asked test question because this doesn't tend to change, if you are asked what fracture is most commonly associated with neurovascular injury, it's supracondylar fractures. Not the kinds of fractures that we're going to see in clinic, but the ones that show up to the pediatric orthopedic surgeon and to the emergency department. But that is the correct answer. And I've definitely seen that come up on my many times that I've had to take the CAQ. So it is also considered the fracture with the highest complication rate. Type 1s are non-displaced. Type 2s are displaced with the cortex intact, and whether or not those need intervention for reduction or pinning depends on how displaced it is. And type 3s we're never going to see in the office, hopefully, because those look horrendous and people are miserable and they end up in the emergency room. So this is a standard type 1 that we'll see, and you can actually see the fracture line kind of coming through here, and you can see the same thing on the lateral, but the anterior humeral line, if you draw that line, is intact, and the radiocapitellar line is intact on both views. So this can be easily managed conservatively in a long arm cast, depending on the age of the kid, you know, and what time of year it is. So if it's summer, you know, oftentimes I'll just do 2.5 to 3 weeks, get them out if the kid can be careful so that they can play in the pool, but still not have them do jumping activities or sports. It just depends on the reliability of the kid and the parents. Sometimes these need to be in a cast for 4 weeks. If the parents are like, it's just not going to happen, I can't restrain them, they're just nuts, then we keep them in a little bit longer. These type 2s, this one did get reduced by the orthopedic surgeon. This was a super tough kid who came to Mayfield Village, I don't know, about 8 weeks ago. I just saw her back in Solon to check her range of motion. So I assumed that she was just going to be a really easy supracondylar fracture because she was swollen and sucked it up. Like, she fell the day before and she was a little swollen, a little painful. Mom's like, but she looks so much better this morning. I almost didn't bring her in. I mean, this kid came in with minimal limitations of range of motion and looking pretty comfortable. So, you know, never are the kids with high pain tolerances coming in with parents telling you that. They're like, I don't know, they complained some, so I brought them in. I thought maybe we should look at it. So the good news on this kid, the radiocapitellar line is intact and the anterior humeral line is intact. But because she's obviously a little extended and a little distracted here, I did have the pediatric orthopedic surgeons take a look, and they said it was fine to manage her in the long arm cast. So we put the long arm cast on, and Fred pushed on it a little bit. And then I checked x-rays afterwards to make sure that we didn't cause the fracture to move from the manipulation of putting the cast on, and she looked fine. And we got x-rays. These were her x-rays at a week to make sure it didn't get worse, and she looked fine. So we brought her back another 2 weeks later because she was a gymnast. So she was in the cast total, I think, for about 3.5 weeks. And then we got her out, and I saw her last week in Solon, and she's going back to gymnastics now. She has about 10 to 15 degrees decreased range of motion in flexion, but she has full extension. If she never gets that flexion back, she'll be fine. For gymnasts, full extension is really important, but all people can live with a little bit of decreased flexion compared to the other side. This one, you know, these are a type 3, and we'll cry if these come to our clinic. So these, you can see why this can cause neurovascular injury. These are pretty significant. So mostly these are going to go to the emergency room, and nobody's going to miss these fractures, obviously, but just so you could sort of see what they look like. So the simple type 1s, which are either you can see the fracture line and there's no distraction or displacement, or you just have a fat pad, is a cast or a sling. Again, the vast majority of the time, it's going to be a cast because we're seeing kids who are really active. If it's a 2 or 3-year-old, I will cast for 2 weeks and bring them back. If it's a 4 or 5-year-old, sometimes they'll be in the cast for 3 or 4 weeks before we bring them back. It kind of depends on the age, because the 2-year-olds are almost completely healed at 2 weeks. So anything else, we have peds ortho C, or we will have them take a look at, and then we'll take care of. Again, they can get loss of range of motion. Extension bothers people the most that are in upper extremity weight-bearing sports. A little loss of flexion is not going to really bother anybody in any sports. Again, these neurological injuries are typically happening in the type 3s, so hopefully we will never see those. And then the vascular injury, there's Volkmann's ischemic contracture is the name of it. I don't think you really need to remember that. That's not going to come up on the test. Ulnar nerve palsies are pretty common, and then changes in carrying angle so that you get cubitus varus or valgus deformity can happen sometimes too. Further elbow stuff, again, in the spring, we will be seeing a fair amount of this. We just got through this season. This was sort of a typical 13-year-old pitcher who had kind of achy medial elbow pain for a while. So, 6 to 8 weeks. And then with one single hard throw, felt a pop, had a lot of swelling, decreased range of motion, a decent amount of pain. Always important in these kids, whether they are chronic or acute, to evaluate the ulnar nerve, because the pitching motion can cause ulnar nerve injury and chronic stuff. So this, you can see he has a little bit of avulsion of this medial condyle and epicondyle, and this is the comparison to the good side. So in young throwers, we will always, always, always get comparison views of the other side, because we don't know how wide this physis is supposed to be. Now, this one is obviously widened, but if they just have a Salter-Harris 1 or stress fracture in this medial epicondyle physis, you don't know how wide it is supposed to look. So this is very obviously different from his non-affected, non-dominant side. So these, and insurance companies do not currently give us a hard time about doing comparison views of these. So these and the proximal humeral physis, we're always going to be getting comparison views, because you don't know how wide the physis is supposed to be in any given kid. Sometimes if they've had x-rays done in the emergency room, I'll call it good enough. If I feel like the diagnosis, if I feel very strongly that I'm not going to change my management, I won't always send them back to get more. But if I'm seeing them the first time, I'm always going to get bilaterals in the throwers who are, and again, sometimes, when you see a 16-year-old, you usually don't need bilaterals because most of them are going to be done growing at that point. But sometimes you see the 16-year-olds and you're like, oh, that kid could pass for 13. I want bilateral elbows on that kid. So when possible, I do try to see these kids first to make sure I really need the bilateral. So if they have minimal displacement, so typically it's less than 3 millimeters, you can do a sling, a splint, or a cast. And that will all depend on, again, how reliable is the kid going to be? And how uncomfortable are they? We really, really, really try to manage these throwers in a sling if we can count on them to be reliable, because elbows get very stiff and they lose a lot of muscle mass. So if we have to put them in a cast, they're out a lot longer, because then they have a lot more rehab to do. So I remember Sue's had a really, really unreliable kid who didn't follow the rules, and she eventually had to put in a cast. Because he kept coming out of it and kept trying to throw. So if you can get them in a sling, we try to aggressively get range of motion going at 5 to 7 days. If we put them in a cast, we try not to do it longer than 2 weeks, again, so we can get them out and get them moving at 5 to 7 days. If they have more than 3 millimeters of displacement, at the very least, I have the orthopedic surgeons take a look. And again, like, our guys are really good about responding to us. If we take pictures and text it to them or do the whole Epic thing, they respond to us pretty quickly. And most of the time the kid can just hang out in the room while we're waiting for them to call back. Obviously, if there is neurovascular compromise, we're going to send them to the emergency department and have ortho take a look at them there. So we do a lot of strengthening at 6 weeks. This is almost always due to mechanical issues and doing too much throwing. So there's a lot of re-education, and we do have a couple of physical therapists and occupational therapists who really love to work with throwers. At Druzynski and at Mentor for sure. And so we will try to hook them up for at least some of their visits with the throwing people, so that we can make sure as they're resuming throwing, they're starting with good mechanics. I try to warn them when we see them, when they truly have an avulsion fracture as opposed to the stress injuries, that it's going to be 2 to 3 months to get back, because there's going to be a decent amount of rehab. Because once they start to feel better, they're like, can I pitch? Can I pitch? Can I pitch? When can I pitch? Can I pitch now? How about now? And so, like, if we tell them up front that it's going to be 3 months and they happen to do it in a shorter time period, they feel really happy. But if they think they're going to get back in 6 weeks and it takes 3 months, they're really grumpy. So I try to tell them up front it's going to be 3 months. And then if it happens to be shorter, everybody is happy. This was a kid that I saw who had a non-fusion and an ossicle formation. He never presented with his original injury. I saw him his junior year of high school, and this was managed conservatively. We just shut him down briefly, let it settle down, and then got him back to throwing, and he ended up pitching D1. And he was mostly entertaining because we were trying to get him to go do his return to throw program with one of the throwing physical therapists, who was like, no, these are the number of throws you can go do at practice, because I'm terrified because this kid was pitching like 90 miles an hour and the physical therapist was not willing to be his catcher any longer, but he ended up doing great. So this, definitely the pediatric people, you need to know this, the sequence of ossification. This is also something that could pop up on the CAQ. So again, worth memorizing at the very least for your CAQ. And then it's something that you can just have in your phone or look up. So when you're looking at an elbow, as Ben and Beer will complain all the time that, there's fractures everywhere. The sequence of ossification is, the mnemonic we use is Crotoe. So capitellum, radial head, internal stands for medial epicondyle, trochlea, olecranon, external lateral epicondyle. And they ossify at 1, 3, 5, 7, 9, and 11. So it's convenient that at least skips the numbers in odd numbers. So this is useful because if you are seeing what you think is, you're not sure if it's a fracture or not in the lateral epicondyle, and the capitellum's not ossified, that's a fracture in the lateral epicondyle, right? But if you have all of the other areas are ossified and you're seeing the lateral epicondyle, that may or may not be a fracture. And again, comparison views of the other side are always helpful. And I think that's the easiest way to do it. But, if you are seeing, an olecranon growth plate ossified, but not the radial head, then this is a fracture of the olecranon. So, and again, these are just the pictures, obviously. Medial epicondyle, capitellum, lateral epicondyle, radial head, and trochlea, and then the olecranon on the side. Oh, there we go. Fingers. I like to talk about fingers mostly because the whole world thinks we never do anything about finger fractures. Everybody's like, well, I'm not going to come in for a finger fracture because you never do anything but buddy tape. Which is true, except for that in kids, a lot of times that's not true. So I always bring up finger fractures. This one, they're almost always the same story. So the vast majority of the time, it's going to be a ball hit the end of my finger, or I jammed my finger. Those are the two things that people will say to you. And when you say, what do you mean you jammed your finger? Well, the ball hit the end of my finger. Occasionally it is another player ran into the end of my finger, but it's always something ran into my finger. So this kid had swelling and decreased range of motion of her PIP. And this, you look at this, and I looked at this and was like, this isn't terrible, but you can see it involves about 50% of the joint space, and the joint looks a little bit distracted. So I did show this to hand, and I have not seen another one of these fractures since, but this is what's called a unicondylar fracture. So there's these are the little condyles of the finger. These are inherently unstable. So she got these cute little pins in her finger to reduce this joint space and to keep this fracture from sliding off. So when you're looking at finger fractures, again, remember 30% of the joint space. And again, occasionally you have the hand surgeons take a look and they say, no, it's good, just buddy tape. And you're like, okay, but it's always better to have them take a look than to miss something really important. This one with this poor kid came into clinic. He's of course a wrestler and was injured many days ago because wrestlers never come in. His finger got stuck and twisted, and he had swelling and bruising, which they ignored. And his dad was a former wrestler and a real joy to have in clinic. We always look for rotational deformity. So having kids make a fist, you can see this kid's finger crosses over the little finger when you have them make a fist. So this has rotational deformity, which can add significant issues with function as you go through life, particularly if it's on your dominant side. But if you think about gripping a bat, if you think about, gripping a golf club, or, depending on what you do in life, carrying boxes, like this is going to get in the way. You cannot tolerate this. And what was interesting about him, if you look at his x-rays, these are his pre-reduction x-rays. These are not super exciting looking, right? Like this physis is wide. compared to this one and this one. And so what happened is he actually twisted through the growth plate. And I had a hand surgeon take a look. I sent the pictures and oh no, actually he was there that day. I showed it to him and they were like, yeah, that needs to be fixed under sedation. Then the dad said, we're not doing that. So they just gave him a little digital block and yanked on him and reduced him in clinic because the dad refused. And then he didn't follow up. So I assume that the kid and his finger both look fine. But I've had probably 2 or 3 of these, with significant rotational deformity in the last year. I had one kid who, unfortunately, it was missed in the urgent care. They put him in a cast and told him to follow up in 3 weeks. Somebody took him out of the cast. The mom said, why is his finger still crooked? It's like, oh dear. So that kid ended up having to have an osteotomy to have his finger fixed. So you don't want to miss those because you can fix them with sedation or, sometimes if your parents really mean a digital block, if you catch them right away. But if they heal, then you have to have a big surgery with complete anesthesia. So that one is tough. This kid, this is what I always stress about when people dunk, and I would prefer that people never dunk. Like this kid was dunking the ball and his ring finger got stuck on the rim and netting and twisted, placed in a splint. And this was actually the kid who, this is what he looked like when I took him out of the cast that he'd been in for 2 weeks. 2.5 weeks. And mom said, why is he still crooked? I was like, oh yeah, because that needed to be fixed right away. So he did end up with an osteotomy. And you can see his x-rays are kind of more impressive looking. So had that been reduced immediately, that would have, the peds ortho people could have taken him to the OR and, sedated him and fixed that and placed him in a cast. But he ended up getting an osteotomy with the hand surgeons. This kid was one that we saw recently, and the dad didn't really tell me why. He was very reluctant to do anything that I was telling him to do. And it turned out they were traveling to Jordan. So I sent him I was wrong. This is not the kid that came out of the cast. This is one that just showed up with his finger looking that way. This is what he looked like. I had Buechler take a look and he said, yes, send him to me. And this was another dad who was like, no, we need to do this today because we're flying to Jordan tomorrow. And so Buechler gave him like a piece of paper telling him to get x-rays while he was in Jordan to make sure it healed okay. And I don't know how he did. Like, I assume it was fine. This was early in the summer this year. Once you get to the phalanx, the angular deformity that you can tolerate is a little bit less. We don't see a lot of these. This is the only one of these that I've ever seen that needed to be fixed. This 14-year-old kid, again, middle finger struck on the end with a ball, tender to palpation, soft tissue swelling, distal phalanx, but had active flexion and extension, but had this little fracture here, which again involves 50% of the joint surface. This one ended up going to peds ortho, and they were able to reduce this just under anesthesia. So they did not pin it, but it put him in an extension splint for 4 weeks, and he ended up doing fine. Right, again, this time a volleyball player, middle finger hit with the end of the ball. This one comes in unable to extend the DIP. You're going to see these all day long, the mallet fingers where they can't extend their DIP. These are super annoying to have. If in this kid's case, there is no fracture and it's all, that the tendon was avulsed, these can take up to 8 weeks to heal completely. If you're lucky enough to have a non-displaced fracture, they usually take 4 weeks to heal, but you have to be in extension at the distal phalanx for 4 to 8 weeks to get these things to heal. They're kind of a pain in the neck. Having had one myself, it doesn't seem like that's going to be so annoying to just have a little splint on that joint for 8 weeks, but it is pretty annoying. So you can do this, you can do the stack splint. I usually give them a few of these foam splints and 2 of the stack splints, just so they have lots of options at home. And this splint can be on the top, it can be on the bottom, it doesn't really matter, but they do get gross and smelly. So giving them several of them and also a stack splint so that you always can be washing one or the other of them is very helpful. If they don't treat it and they come to you 4 or 5 months after the injury, oftentimes it won't heal. If the family really wants to try, we can certainly give it a go and see if it heals. If it doesn't, then the only option is surgery. The vast majority of people choose not to have surgery and just live life with a mallet deformity. If you look, Dr. Goodfellow was one of them, and you guys won't get to meet him probably, but he had a mallet deformity and he just never had it fixed because he couldn't not be sterile, right? So he didn't treat it and just has a mallet finger. Lots of basketball players you will see have mallet fingers just from not treating these things. And again, it doesn't always affect function a lot, but the middle finger is, again, pretty useful for gripping items. And so if we can catch them early enough, we do like to fix them if we can. So again, surgical consult, if there's any rotational deformity at all, at least have them take a look. I've had several families choose not to treat the fifth finger that has a little bit of rotational deformity, and that's typically tolerable, but any of the other ones, they usually have to have it fixed. Angular deformities more than 10 degrees and shortening more than 2 millimeters. These, again, we're going to see all day long. This one happened to be a football player whose hand was kind of in a fist on the ground when he was tackled, but this is also, we're going to see this in kids who get in fights or kids who get angry and punch walls. You see this loss of knuckle and swelling at the fifth metacarpal neck. So this is your standard boxer's fracture. And I have not had a single one of these ever. I don't know if Suze is still on here. Suze, have you ever had any one of these go to surgery, a boxer's fracture? She must be gone. But none, I've never had a surgeon want to take one of these. I tell every single one of them at the first visit that they're never going to get that knuckle back because it will always be less prominent because of that little bit of angulation, because I don't like them to freak out when it heals and their knuckle looks slightly less prominent. It's not generally very obvious, but I like to let them know at the very first visit. In the old days, we said that you had to be in a cast like this. That has changed. So sometimes we'll do a cast with a little bit of flexion just because having it in full extension is annoying, but it's not required to be in 90 degrees of flexion anymore. Our hand surgeons love this brace, the contender brace. And I use that a fair amount in kids who aren't going to play football. Like, you obviously can't play football in this brace. And for most positions, you're not super effective in football, even in the exos or a cast with your fingers flexed, but you can, like a corner can get away with that. You can usually tackle people reasonably well. Sometimes it will really depend on how good your backup is, whether they want the kid playing with a cast on, or whether they're just going to have them rest for a few weeks till they can play with a cast off. So we immobilize them, again, depending on their age and what sport they're playing, for 3 to 4 weeks. In whatever position they are most comfortable. So I recently had a lacrosse player who we kind of did it the way that he thought he would be able to hold the stick the best. It was his non-dominant hand, so it was only holding the bottom of the stick. So we kind of played around with it a little bit. And then you're going to use, they don't have to, after 3 weeks or so, they're stable enough that they don't need to be in any of these splints all the time, but I'll keep them in it for contact sports until it doesn't hurt to run into people with the hand. So again, they still call them boxer fractures on other metacarpal necks. At the fifth metacarpal neck, they say you can tolerate 40 to 50 degrees of angulation, the fourth 30, the third 20, and the second 10 degrees. This is more of a sort of general rule of thumb. This is not something that's going to come up on a test. For the index finger, I'm almost always at least going to have the surgeon take a look at it if it looks like it's even close to 10 degrees, just because function in your index finger is really important. And obviously at every single hand or finger fracture, you're looking for rotational deformity. So if they happen to have rotational deformity with this, they need to go see hand, or sometimes, depending on the peds orthopedic surgeon, some of them will fix these, some of them won't. So ankles, this kid was a baseball player who was sliding into home. We also see it a lot. I don't know why it's home base and third that we see it the most. Pain, initial inability to bear weight. So they meet the criteria, right? So if you're thinking of the Ottawa criteria for ankles, it is the inability to bear weight either at the time of the injury or at the time of their visit, or tenderness to palpation at the medial or lateral malleolus. And if you meet any of those criteria, you deserve x-rays. just remember that athletes are different, and these were all comers to the emergency room. So all of our athletes are going to end up getting x-rays. I've had kids, had a guy at UCLA who on the first play of the game, he took a helmet to his ankle, and he came to me in the fourth quarter and said, doc, my ankle's kind of bugging me. So we had x-ray on the field at UCLA. So I took him back, got x-rays, and his fibula was in 3 pieces. And he played 3/4 of the game on it. So athletes are different. They will suck things up more than regular people. So it's nice. You should know the AWK criteria because it comes up on tests sometimes, but also remember that we don't apply those to athletes. So this kid had significant bruising and swelling, tenderness palpation of the distal fibular physis, pain with talar inversion, and was not willing to hop on that leg. So had some soft tissue swelling. You kind of look at it, you're like, I don't know, is that a little bit wide? Well, as you're learning, you guys are already learning, whenever kids have swelling and pain at the area where your physis is, we treat it as a Salter-Harris 1. And this kid was having trouble weight bearing anyway. So we put him in a boot, came back and rechecked. Oh, sorry, I wanted to put him in a boot. If the parents are concerned, we stick him in a cast. I actually think this kid went in a boot. I would say maybe 10, 20% of the time I have parents say, no, they have to be in a cast. So we recheck them at 2 to 3 weeks. And this kid, we did recheck x-rays on, and you can see here, periosteal new bone. So this is a confirmed Salter-Harris 1 of the distal fibular physis. And interestingly, the physis looks even wider at the recheck. That's just, and I do tend to warn parents too. Sometimes the fractures actually look worse as they start to heal, even though they're getting better. So, but the nice thing about these Salter ones is they heal really quickly. So this kid was able to play at like 4 weeks. They'd been stiff from being in the boot. And so we just had to do some strength and range of motion stuff. He was non-tender and able to run and play. We just kind of got him back into sports at that point. This kid showed up super late, had fallen off of his bike, twisted his ankle 3 weeks before I saw him. He had a lot of tenderness still at his distal fibular physis when I looked at him, and he had an antalgic gait. And you could see on his initial set of x-rays, this little fracture here. And then when we followed him up in a couple weeks, you could see he was already remodeling because he came to me 3 weeks into his injury. So this kid had wandered around on his Salter-Harris fracture for 3 weeks before I saw him. He got lucky and ended up having no growth disturbances. But that, his mom was kind of a suck it up mom. So when we followed him up, this was the side that he'd injured, and this was his uninjured side. And you could clearly see there's periosteal new bone on the right side compared to the left. These days, I probably wouldn't get the comparison view. This is when insurance companies were nicer. So this kid, of course, was the kid of a colleague who, and again, I will say every single Maisonneuve fracture I've ever had also missed in the emergency room. Every ankle injury we see, you'll notice we all start at the proximal fibula and palpate down to see if they have pain. So this kid, his dad was mad at him because he was living at home while going to Case because dad was an employee at Case. I think that he must have come home from a party and was messing around in the driveway with a skateboard and fell and twisted his ankle. Went to the emergency room. These x-rays were read as normal. Dad again was mad at him and finally said, fine, go see Mandy. This was a guy who I did research with back in the old days. And I looked at his x-rays and you can see this is mortise widening. Like this is a significant issue. He was really painful. I palpated his fibula and he had a lot of pain. And so he also had this fibular fracture. So one of our trauma surgeons did his pin. So again, it is super important to make sure that you palpate the proximal fibula and that you look at your mortise views for widening of the mortise, which this kid had. So he ended up doing fine because he only presented a week later, but he was miserable longer than he needed to be because this abnormality was missed initially and because his dad was mad at him. This one, again, this x-ray was read as normal. So girls, these tend to happen between the ages of 10 and 13. Boys, a little bit older than that because their bones, their growth plates close a little later. So these Talot fractures, they happen, and this Talot fractures sometimes come up on the CAQ. And these happen because the way that the growth plate in the tibia closes is from back to front and then medial to lateral. So during the period where this medial part of the physis is almost completely closed and the lateral physis is still a little bit open, and they have a twisting injury, usually an external rotation force, you can get this Salter-Harris 3 fracture right here. And again, this is why we always look at our x-rays. This fracture was missed. And again, this is one where if they come into the office and they're really miserable and uncomfortable and they have x-rays from an outside facility and all we have is a normal reading, this is the kind of kid that we're not going to trust the reading because they're painful and uncomfortable and can't weight bear, that we're going to get our own. If they're already able to run and jump, then those guys, then I'll trust the reading from an outside hospital. So this kid gets a CT scan to make sure that this joint surface is congruent. This happened to be one that I showed to Joe Sun Hing when the CT was done. It looked good. So this got casted and a little bit of internal rotation. They need to be non-weight bearing for a month to start. This is, again, the Salter-Harris classification again. So this is a Salter 3. And that kid, this poor kid, she was so terrible on her crutches and her non-weight bearing that she fell and broke her wrist. So then we put her in a wheelchair. So again, the Salter-Harris again, and then really quickly, a little bit of hip and pelvis stuff. We're going to see a lot of these. We see these in soccer players too. But track athlete coming out of particularly if you're coming out of the blocks, they feel a pop in their hip, they fall to the ground. They're generally miserable. These kids have trouble weight bearing. One of the guys who did fellowship at UCLA 2 years above me had one of these on the football field. And he's like, the kid was in so much pain. I had him transported to the ER because I thought he dislocated his hip. So these kids hurt at the time of the injury. And I had one of my neighbors, like when at my old house, they came home from a baseball game and they're like, Richie's dying. And he like could barely hobble, to a lawn chair so I could take a look at him. And he had an avulsion fracture of his ASIS. They hurt a lot initially. These kids will look impressive. It's not bad to send them to the ER because if you miss a hip dislocation, that's bad. But this is, some of these are huge. So these huge ones, they're going to be really miserable. I've never had one of these that needed surgery except for a kid who had an AIIS avulsion, and his healing was so significant that he had lost almost all the range of motion in his hip because the healing kind of came way out over his acetabulum and he couldn't move. And so the surgeon went in and revised his callus. So we see these a lot in soccer players, sprinters, football players, martial artists. So soccer players, when they kick the ball at the same time as another player, you get a huge eccentric load. And they generally will report hearing a pop or a snap. They don't always. I think we see ASIS the most, followed by AIIS, and then probably the ischial tuberosity, and then the lesser trochanter. These you need to know, especially ASIS and AIIS, which muscles attach there, because that sometimes comes up on the test as well. So they're all the ischial tuberosity. I think 90% of the time, this is a cheerleader who's not flexible enough, who does a split jump or a high kick, or does that horrible thing where you jump up in the air and then land in the split position on the ground. And those kids are just miserable because it's really hard to rest it and you have to sit on it, and no one will take a donut to school. The iliac crest ones we see, I think, in soccer players, wide receivers, and running backs, because it's usually with a change of direction. So these are just do what you have to do to make them pain-free, get them into physical therapy, make sure you get their strength back so they don't get an ACL injury when they come back from being weak. And they can take, a good 8 weeks to come back to play, depending on how old they are and how uncomfortable they are. So that's all I have to say. Does anybody have any questions?
Sorry. Yeah, Mandy, could I ask a quick question about the articular surface percentages? So yep. I think I'm just a little bit confused by what you're counting from that. So some of the ones where I guess, it's 25% mattering a little bit more. Are you saying what percentage of that joint would be affected by the fracture? Or because I think in my mind, I'm thinking of the crack going to the joint and it's 2% of the joint versus I think I'm just visualizing it wrong. Do you mind explaining that one more time?
So the fracture fragment, if the where the fracture line actually goes through from the fracture fragment is more than 25% of the joint. So if you're looking at this one, for instance, like the fracture, the spot where the fracture piece comes through, the fracture line comes through the joint, this is about 40% of the joint space. So 50% would have been over here, and like 10% would have been if it was over here. Does that make sense?
Yeah, no, thank you. I appreciate it.
Do you mind
Anybody
going
else?
to
Go.
the physial avulsion fracture slide? So just so I can take a screenshot of it real quick.
Oh, yeah. Oh, I'm going the wrong direction. No, I'm not. I was doing it right. Sorry, my bad.
Thank you so much.
Yep.
Got it. Appreciate it.
Yep.
Andy, are you able to share these slides just so I can like look at them later too and reference and like compile
Yes,
some like
I
quick notes into a little
will.
like cheat sheet for myself?
Yep, I can, I think I can save it to the S drive, right, Suze? I have access to that. Oh. Suze, oh no, Suze isn't on here anymore. If I don't, Suze will. We can share it to the S drive for you guys.
Perfect, thanks.
Any other stuff? All right, guys. Have the best day.
Cool.
This
That
is
was awesome.
Hamlet.
Thank you.
Thanks so much.
This is our newest addition.
Oh.
He's the best.
When is Bring Your Cat to Work Day? Is that next week on
It
Tuesday,
should be
Mandy?
every day, darn it. We'd be so much happier if we could.
I think we should do it. Yeah,
I could bring my dog too.
definitely.
All right, boys. Have a great day.
Thank you.
All right,
Oh,
see you
and
guys.
Megan, sorry, I didn't realize we have a girl too. Hi, Megan.
Thank you.
Bye, guys.